Welcome. Today we're going to talk about our sepsis program here at the Baptist Health System in 2017. So let's go over some of the definitions. So sepsis is infection with a systemic inflammatory response. Severe sepsis is both of those plus organ dysfunction. Please note that organ dysfunction can be lactate greater than 2. Um, Septic shock is all of the above plus persistent hypotension. Persistent hypotension means 2 blood pressures in the first hour after fluid bolus with a mean arterial pressure less than 65 or less than 90. The other definition for septic shock is severe sepsis with a lactate greater than or equal to 4. So if we identify a patient as having severe sepsis or septic shock, we should call a sepsis alert. This notifies the EICU to begin tracking our metrics. So we have the 3 and the 6 hour bundle as metric. So here are the 3 hour bundle. We have to get a point of care lactate within 180 minutes of the time that sepsis is identified. We need to give broad spectrum antibiotics also within 180 minutes, and it has to be an approved antibiotic. Blood cultures have to be done prior to the antibiotic. And if the patient has a lactate greater than or equal to 4, or if they're hypotensive, they need the 30 cc per kilo bolus. The best way to meet this metric is to use the BHS sepsis order set, which has all these metrics in it. So what's in the 6 hour bundle? Well, the 6 hour bundle requires that we repeat all lactates that are greater than 2 and after the fluid bolus. If the patient has persistent hypotension, again, this is 2 readings of less than 90 systolic or mean arterial pressure less than 65 after fluid bolus, have to have vasopressors. And if they have vasopressors, they have to have a central line. Then the patient has to have a focused reassessment for perfusion or CVP plus SCVO2. So remember, it has to be one or the other, and we'll get into the elements of the focused reassessment. But it's either CVP and SCVO2 from the central line or a focused reassessment. So a focused reassessment is needed for patients that have a lactate greater than or equal to 4, have initial hypotension, or have persistent hypotension after a fluid bolus. Now, Cerner allows for the focused reassessment by going into any free text area and marking / capital sepsis in the free text area, and it brings up all the elements that you need to document. You must make sure that there's a current set of vital signs entered by the nurses prior to completing this. Alternatively, you can complete the focused reassessment on the paper form on the sepsis screen on the back side of the sepsis screen. So here's the focused reassessment on the back of the sepsis screening tool. And this is the top half of it. And if the patient requires a central line, you can just document the SCVO2 and CVP. Now, you do not have to optimize these, but you do have to document them. Here are the acceptable 2-drug combinations for sepsis. Now, note that both of these drugs have to be started within the first 180 minutes if you choose to use these. Here are the acceptable monotherapy drugs for sepsis. The best way to comply with the antibiotic and all the sepsis metrics is to use the shared BHS sepsis order sets. They'll have the right antibiotics. It'll have the appropriate 30 cc per kilo bolus. It'll have the point of care lactate and the reordering of the lactate. All the metrics that you need to comply will be found there. So it's important to use the sepsis order sets once you identify the patient as being a septic patient. A common reason for falling out on this metric is using vancomycin as a monotherapy for sepsis. Again, you'll note that this is not one of the acceptable monotherapy drugs. Again, don't use the Tenet sepsis orders. Use the BHS shared sepsis orders. Here's the front page of the current sepsis screening tool, which is initiated by the nursing staff. Here's the bottom half of the sepsis screening tool. Here's another tip to compliance. In all patients that have severe sepsis identified, those patients that have serious criterion of a source, and then most of these will be lactates greater than 2, it's better to go ahead and give the 30 cc per kilo bolus, even if the patient's not hypotensive now, because if it's identified within 6 hours of the diagnosis of sepsis, the patient will meet the metric and need to receive the 30 cc per kilo bolus. So what about patients that may meet the criteria for 30 cc per kilo bolus, but you don't think they should get it? Say they have a lactate of 5, but they're also a renal failure patient, hypertensive and short of breath with a volume overload on their chest x-ray. Well, I would tell you to use your judgment and not do things that you think are not good for the patient just to meet a metric. However, there are no acceptable reasons per CMS for not giving the 30 cc per kilo bolus in patients that meet the criteria. But again, we're not just working for a metric, that we want to make sure that we're using our clinical judgment as well. I would say that you just document your thinking in these patients. However, most patients can receive the 30 cc per kilo bolus if they meet the criteria. Couple more points. The sepsis bundle is an all or none, so if you miss out on one item, like repeating the lactate, it counts as a 0. We track compliance for the system, but we also track it for each doctor's, and we send the doctor an OFI letter if they have a fallout so that we can improve this metric. Obviously, we don't want to just improve the metric, we also want to improve our care of these septic patients, and by paying close attention to our care of them, hopefully we will improve their care. So some final hints on how to comply with these metrics. First of all, use the BHS sepsis order sets. Save it to your favorites. Give the 30 cc per kilo bolus in most severe septic patients. Don't use vancomycin as a monotherapy. Used antibiotics in the approved list after blood cultures. If you use the sepsis orders, the BHS sepsis orders, they have the correct antibiotics there. Repeat all lactates that are greater than 2. Again, blood cultures before antibiotics. And notify the EICU of all septic patients to help them track our metrics. They're also available for any questions you may have. So thanks for your attention, and I hope this was helpful.